Louder? How about this? Is that all right? Welcome to everyone. Yeah. So it's on now? Yes. Going around a bit. So have you done this sort of thing? I think I'll bring mine.
I'll turn mine off.
Have you done this sort of thing?
As soon as you start talking, it'll come through.
Okay. Well, good morning, everyone. And thanks for coming. And it's just wonderful to see so many people here today. And I know part of the reason is because of the building, but it's also really nice to catch up with so many people. And I can tell by the level of conversation that it's a really good networking opportunity as well. So we want to encourage that further as we move through this morning session. Just to remind you that this is being videotaped, so if you do want to ask questions, we have some roving mics, so please make sure you have the mic in front of you before you start talking, and it would also be nice if you could introduce yourself briefly, name and where you're from. We have three guests here this morning. We have Judith Dwyer right in the centre, Justin Bilby and Maria McCready, and I'll tell you a bit more about these famous people in a minute. But first I want to welcome you to do the welcome to country, and I'd like to acknowledge the Kaurna people who are the traditional custodians of the land, and I would also like to pay respect to the elders, both past and present, and extend that respect to other Indigenous Australians who are here present today. This session is an idea that was conceived in, I think it was in Wellington at the Health Services Research Association of Australia and New Zealand last December. and John Carnan, who's at the back. John, do you want to... came up with this idea of doing something to reduce the gap between research and policy. We then, at the end of the conference, as you do, met in the Qantas Club. So there was John and Carol and I, and with their nice wine, we plotted and planned, and this is what happened. So I guess we have to thank the Qantas Club wine for that. But we also have, the three of us come from different organisations, and collectively the three organisations have helped bring this together. So John is the Vice President of the Health Services Research Association of Australia and New Zealand. Carol Davey is works here at SAMHRI, and with her boss Alex Brown has been supported to allow us to have this venue and do a lot of the background work and secretariat work for that. And my name is Ellen McIntyre, and I'm the Director of the Primary Healthcare Research and Information Service, and you would have all picked up something from our table as you walked in this morning. So I'd imagine some of you are going back now to clean your keyboards with the brush, or clean your glasses with the lens cleaner, or use your pen with the pens that we've provided. All we ask you to do is that you actually have a look at our website and join in the work that we do, so that you can find out more about primary healthcare and a whole bunch of things around that. Now, this session will finish at 10:30. What we'll start off doing is each speaker will give about a 15-minute talk about what they have managed, what their research has achieved in terms of changing the way we do things. And they'll talk about the processes and what worked, what didn't work, what are some of the learnings from that. You'll have an opportunity after each speaker to ask questions, and then we'll bring it together for some more general questions towards the end. We'll finish that session at about 10:15, and then give you time to do your evaluation, because this is the first of 3 sessions, and we want to know how we can do things better next time. So please take the chance to provide us with that feedback. So, unless there's any, well, you know where the exit is. You've had your breakfast. If you feel you need more coffee and food, please help yourself, and we'll get started. So our first speaker is Professor Maria Macreades, and she is the theme leader for Healthy Mothers, Babies and Children at the South Australian Health and Medical Research Institute, which is here. She also directs the University of Adelaide's Women and Children's Health Research Institute, based at the Women's and Children's Hospital. Now, Maria is a research dietitian, and she's committed to improving the nutrition and health of mothers and their babies through the conduct and translation of high-quality research. She's published over 200 peer-reviewed papers, and her group has conducted some of the key intervention trials involving omega-3 supplements in perinatal nutrition, and has recently been recognised as a National Health Medical Research Council Centre for Research Excellence in Foods for Future Australians. Now, just before you start, just to let you know, I think I've mentioned we are taping this, so please be aware that when you do ask questions, to mention your name. Anyway, Maria, we're not going to use PowerPoints, but we'll just wait for you to say what you want to say.
Thanks very much, Helen. And thank you for asking me to speak this morning. I feel that having come from a clinical trials research background, I still feel like a huge novice in the area of translation and trying to translate the research that we have done into policy relevant areas. So I thought I would talk a little bit about the fatty acid work that Alan has mentioned, that has really started in the very early 90s and still continues today. So I thought I might give you a bit of a summary of what the science actually says, because I thought that, you know, you created the evidence, and then once you had the evidence, it would be pretty straightforward, or people would see the logic in being able to actually take that on board. And so I'll actually summarise what the evidence is now telling us, and then I'll tell you a little bit about what actually happened in terms of food policy or food regulations, and some of the battles to actually get some of that changed. And then I'll talk a little bit about another area that we've been active in, is iron nutrition during pregnancy, and what may or may not be the better ways to deal with things like anemia in pregnancy. So in the fatty acid area, our main interest has been one of these long-chain fatty acids called DHA. DHA is one of these lipids that's basically found in high amounts in breast milk, in fish and fish oils, in the lean tissues of red meat, in egg yolk. So why would this be important for babies? Well, it is quite abundant in breast milk, and we know that it's actually accumulated very heavily in the last trimester of pregnancy and during early life, and accumulates well in the brain and in the nervous system. We know from animal studies that animals that are fed deficient diets actually have issues with learning and with visual acuity. And why did people get really worried about DHA in infant nutrition in the very early, late 80s, early 90s, was that the publication of an original study in premature babies that suggested that these babies who were being fed formulas that at the time did not have any long-chain fatty acids in them, but they also were very rich in the competing omega-6 fatty acids in vegetable oils, and they were very similar to the sorts of formulas that were given to rhesus monkeys that showed visual loss with these formulas. So there was a suggestion, so there was this huge drive to actually do some studies and see whether if we actually included these long-chain fatty acids in infant formulas, whether we would be improving the brain development and the brain function of babies. So the work started, and a lot of it was driven by the infant formula industry, because there was clearly a desire to improve the products that they were manufacturing. Of course, the breast milk concentration of DHA varies with the diet. So if you're a vegetarian, you have lower levels, and if you eat an omnivorous person, you have medium levels, and if you eat lots of fish, you actually have higher levels. So there's actually scientific questions about actually if DHA is important, what is the best level, and what should lactating women and women who are breastfeeding be eating. And so from all the work that's happened really over the last 20, 25 odd years, we actually now know that it's the babies that are born premature that are the ones who actually need probably most support with DHA, because they miss that last trimester of pregnancy, being born early. And during that last trimester of pregnancy, there's basically a huge active transfer across the placenta into the brain and nervous system and all of the tissues, probably at about 3 times the dose that's currently in most formulas and also in most of our breast milk. So they probably need a bit of extra support. And that's what the studies are basically showing. If you're a healthy term infant, well, if you're born healthy and at term and you've had the full benefit of that supply, and you're breastfeeding and you're getting a good supply of DHA, well, actually you probably don't need any extra supplementation. So do the healthy term babies actually need extra DHA? Well, we still don't fully know, and for long-term development, there's probably not. But there are some data that are relatively consistent that if the level in formula is about 0.3% of DHA, that you do have better visual resolution during infancy. And then you think, well, so what? Does it really matter? Does the vision actually continue to improve? Well, no, it doesn't, because everybody's the same by about 1, 2, 3 or 4. So if you're a healthy term baby and you're breastfed, that's actually the best outcome. And I'm sure Alan will be very glad to hear me say that. And do you really need supplementation in infant formulas for healthy term babies? Well, you know, probably not. But for preterm babies, then yes, there is a need for some DHA and probably extra DHA regardless of whether you're being breast or formula fed. So while these studies were actually happening, there was also a lot of discussion about growth rates, and in one of the original studies there was a suggestion that maybe supplementation with DHA was associated with reduced growth. Obviously that set a lot of alarm bells, and the reaction was to add lots of another omega-6 fatty acid called arachidonic acid. So when the regulations changed, they changed relatively quickly, and the addition of arachidonic acid was mandated in the regulations without any real assessment, because they said, well, actually, if you add DHA, you have to add arachidonic acid, and you have to add it at twice the level. Now, that happens to be in our Western diets what is present in breast milk. There's about 0.2% DHA and about 0.4% arachidonic acid, so that was the ratio. But we now know that actually, if DHA is going to work in infant formula for term infants, you need at least 0.3%, which actually means you've got to put double the amount of arachidonic acid, which starts to actually go outside of the range of what might be in breast milk. But nevertheless, that actually really does highlight that, of course, you know, issues of safety are actually, and risk are perceived to be very important, and quite rightly, but sometimes there is actually change to prevent risk without the sort of evidence that you actually may expect. Not saying that you actually need to do the same, the onus of proof will be exactly the same, and it won't be and it shouldn't be, as it is for efficacy, but the balancing the risk and the benefit, and sometimes not overreacting for a perceived risk, I think is something that actually is important. So what actually happened with the regulations? After the initial set of studies, it was mandated that DHA could be added to infant formulas. It was as an optional nutrient, which actually made a lot of sense. So not everybody had to add it if it was an optional nutrient. But as I said, if it was added, it needed to be added in this 2-to-1 ratio. And what does that imply for breast milk? And if you're thinking about preterm babies, that actually the data are showing that you need a lot more. You probably need about 1%. So what does that mean for those formulas? That you need to add 2% of arachidonic acid. That's actually never found in breast milk. It's actually, you know, no one has ever tested that in a clinical trial, in a natural experiment. It actually doesn't even exist in what you would normally expect. So, of course, people don't want to supplement at that level, and then the regulators said, well, actually, because that doesn't exist, we'll actually cap it all at 1%. So the total can't add up to more than 1%, which actually means you never cover the requirement of a preterm baby. So that is actually a bit of a problem. And you think, well, actually, okay, so if you are then thinking about the woman providing milk for her child, who is preterm and is expressing milk, what happens to her milk when you supplement her with DHA? Well, it goes up, but the arachidonic acid level never changes. So even if you give her enough so that she's producing milk that's at that 1% level, which is typical of the fish-eating communities in Japan, their arachidonic acid level never changes. It's always still at 0.4. So the regulations there don't actually quite match. And it wasn't until there was actually enough data that we were able to do a systematic review involving both term and preterm studies that when the Food Standards Code for infant formula was being reviewed about 5 years ago, that ratio was dropped to be at least 1:1. But that took about 10 years, and it was actually something that was done through Codex, so that the international standard that forms the basis of the food regulations that many countries adopt. And that actually becomes really important because that's actually the basis of a lot of the free trade agreements that actually allows movement of food across countries. It's also subject to the way countries trade with each other, and also the local industries and whether they'll be able to make any money. One of the other interesting asides that was happening about this 2:1 ratio is we could never really understand where the 2:1 ratio came from, other than it was typical what was in Western breast milk in the US. But we also found out that at the time that there was a company who had a worldwide patent of that ratio that ended up being the main manufacturers of the supplement or the ingredients that actually were to go into the infant formula. So there's a lot of complex issues, and if you're thinking about those sorts of things, especially around food policy and food regulations, there's issues of trade agreements, fair practice, not disadvantaging people, and along the chain, everybody needs to be able to make a profit, so that there's actually a dollar value or an economic implication, and things will never actually get to market if there is not an incentive for everybody along the way to be able to make some money. So I think that's sort of been a huge learning for us, and just because you might produce a beautiful clinical trial, if it actually doesn't have anywhere to go and somebody can't market it somehow, or it's not going to, and I guess from the health system, going to be a way maybe to, there's going to be an incentive somewhere along the line either to make money or save money, then I think that's actually a pretty important consideration. The other question that was asked was around some projects that you've been involved in that actually didn't really end up seeing the light of day, and so I'll be short here. And this is around the use of iron supplements during pregnancy. So people often do suffer iron deficiency or anemia during pregnancy, and we've got beautiful studies that show that the best response is with 20 milligrams of iron. Most without side effects, without black stool, without gastrointestinal side effects, and so that the woman has all the appropriate comfort. All the supplements for iron to treat anemia that are listed with a TGA have at least 80 milligrams in them, and they're the ones that cause all the side effects. And iron's really cheap, so there's not actually an incentive for anyone to change, and more must be better. So even though we know we can do better, treat effectively without side effects with a low dose, you can't actually get any. With the appropriate dose, you can get very low dose, 5 milligrams in a multi-supplement, and you can get very high dose, but you can't get 20 milligrams on its own. So I'll stop there.
Well, thanks, Maria. That's been quite interesting. Has anyone got any questions that I'd like to ask Maria? They've got two roving mics in the back. Down here. If you can just identify yourself and where you're from.
Good morning, I'm Craig from the Joanna Briggs Institute in Adelaide. From your talk, I got a couple of points. That one of them seemed to be that if, as you're doing research, you are networked into a body that has a mandatory role, that is indeed a very effective mechanism for transferring knowledge from research into policy. And it seemed like a very fluid arrangement from what you were saying. So there was an original policy decision, new evidence came to light, that policy decision was modified. Was that as quick as it sounds when you talk about it? How did it go?
I tried to make the point that happened over a 20-year period. When I first started working in the area, Food Standards Australia and New Zealand were actually in the process of updating the regulations for infant formula. To finalise that took 10 years, and they're now reopening the file and want to actually look at what they should update now. But I think that's probably not going to happen for quite a while. The relationship with both, having relationships both with the regulators as well as the industry, I think, has been important. But people, the regulators and the industry are clearly governed by different things, and the industry tend to look, they are driven partly by the research, but they're also driven strongly by their markets and their market share, and what they think will sell most product. And sometimes you're in favour with them and sometimes you're out of favour, depending on whether they like what you're saying. And the food regulators and the people who are looking at those sorts of regulations are hugely driven by risk and seem and the last thing anyone wants to do is actually create any new risk where one doesn't exist, and that's quite appropriate. And so they're coming from completely different points of view. And I think the example that I gave, I was trying to show that sometimes being so risk averse can actually create other problems, but it's actually a pretty difficult balance to find. And their main job is to actually create regulations that will protect the public. So they have to be risk averse by definition.
Any other questions? Okay, we might move on to our next speaker then, Professor Justin Bilby. And Justin's from the University of Adelaide, where, as most of you know, he's the Executive Dean of the Faculty of Health Sciences and has been there since 2005. Prior to that, Justin held the position of Professor and Head of Department of General Practice at Adelaide Uni. He's been involved in research and evaluation with workforce planning, primary care financing, chronic disease and the quality use of medicines for over 20 years. You know, it really doesn't show, does it, that these speakers have been busy for so long. So it must say something about doing research. He's published widely in asthma, diabetes, point-of-care testing and primary care financing, and he's been intimately involved in national and state health policy research. He's been on a number of committees in relation to that. Justin's been a member of the Strategic Research Initiatives Working Group of the NHMRC, and he's a commissioner in he was a commissioner in the National Hospital and Health Reform Commission, and he has extensive experience in the health system reform, having been a member of the Clinical Senate and SA Health Performance Council. So Justin, tell us your story.
Thanks, Ellen. It's a pleasure to be here. It's just a fantastic venue, and it's lovely to see so many people here today in this magnificent view. I want to pick up three things, three lessons I've learned over the last 25 years about working in this really quite exciting space, but very challenging. One's the political reality of being in health work. It's just basically, and I'll explain why I'm going to pick that one up. I want to talk about the value of community in clarifying whether a very good idea is not logical in a sense of moving forward. And then I want to pick up the issue of gaps in services and providing solution-based research versus something that's a good idea conversation. It's really 2-3 key points. If you take that away, I'll have achieved my little bit of 15 minutes of fame. I want to go back to the National Health and Hospital Reform Commission. I was one of the 10 commissioners. So 2008, we were charged with, my background is general practice primary care for people that don't know my clinical background. We were charged with looking at the healthcare system for the next 25 years and building a new system that might actually work a bit better. So 10 of us got together, a group of primary care clinicians, hospital-based people, very wisely, some state health politicians, ex-health ministers and ex-premiers, some people who are very experienced politically, and some very good health policy experts, including people like Stephen Duckett. So we mapped 123 recommendations, 4 very excellent pillars. It's worth, if you ever get a spare minute, just looking at the pillars in the report. And we made the somewhat naive couple of suggestions, and I want to talk about those. One, that the Commonwealth should take over all of primary care, the whole of Australia, to try and build the model that actually integrated. And the second thing is we could create home care, or the right place, right time care, by linking patients or families to one particular team-based practice. So if you look at the evidence, and my area has been chronic disease management, looking at different models of primary care to create integrated team-based care, that seemed logical. There were 2 very good suggestions. So the first thing that derailed it big time was the fact the states weren't happy with the Commonwealth taking over all of primary care. And in essence, they were right. You can't actually, I don't think personally, manage primary care from a Canberra base without having the local flexibility to produce the systems change you need to create innovation. So we've now moved back, and I'll come back to where this finishes in a minute, where the states have taken much more say at a regional level how you manage primary care and build a future around innovation. The second thing was really quite interesting. It's around the patient enrolment within the team-based care or the family enrolment with a clinical practice. And basically the Australian community are not ready for that type of linkage to a single team-based practice. What Australians love is the ability to pick and choose their primary care practices based on their needs. So whether you've got a gynecological problem versus an age problem versus a paediatric problem, Australians pick and choose. They choose what they like in that provider, whether it be nurse, physio, chiropractor, GP, it doesn't matter. Australians value their free choice. So the issue of trying to build team-based care around a model of physio, GP, clinician, and linking to a patient denominator so that you can actually look at the whole client pool, the whole patient pool, has got a long way to go in Australia to debate and think this one through, because we actually don't quite know how to do that. We understand evidence-based-wise why you would do it, because you get this denominator, this group of people, you have a very significant focus of care, but basically the community is not quite ready. So what they did was, which is the classic political process, they set up another pilot. So the National McKinsey Diabetes Pilot is just finishing, and while the report hasn't been released, I think that will be very interesting, some of the findings which seem very positive. The other thing I just want to finish is around the National Health and Hospital Reform Commission is many of the options we suggested, such as the Quality and Healthcare Council, IPA, the Independent Health Pricing Authority, the National Health Performance Authority, were very good concepts as you try and drive a quality agenda across Australia as separate standalone organisations. But with the reality of the change in government, they've merged them into a new productivity commission, productivity and something other commission they're going to move towards. So just, again, what's an inherently logical decision made by one political party will often change when you have a change in government. And that's the reality of health policy. That's the reality of life. There's a political agenda you have to manage. I've talked about the community value, about the issue of patient enrolment and patient linkage, and the value of primary care. And I think where we're moving to now is that the policy area that's opening up as we move forward with the new primary care networks post the interesting move away from Medicare locals to primary healthcare networks and the move to align them with hospital networks. I think what we're beginning to get some sense of possibly a way forward around linking hospital networks, primary care networks, to move forward in a unified manner to provide gaps in services, which is where I want to go to in a minute. So I think what we're looking for now is using our policy advice to think through with your research that crystal balling for 5 to 10 years and think through this is not a short-term solution. Maria's talked about 20 years. My little bit of influence has been over 20 years. It's not something you're going to do tomorrow. It's about building momentum, building your debates, using language that both politicians and the community understand. Bluntly, it's not published papers. It's about getting some précis, and it's the corridor conversations with the key players that make decisions with a very well-structured thought that's important. So getting your language right, choosing that walk down the stairs, you have to have the evidence. I agree with Maria, but you've got to learn how to use the evidence in a language that gives you to alert and tinker with people's thoughts. The political system has many people pressuring it. It's about getting that mix of solutions. So there are two things, and I want to move on now to gaps and solution-based work. And I think this is where we as researchers have to think carefully about where do we value, where's the evidence base empty, as Maria's talked through, where can you gather the evidence? Is it systematic reviews? Is it other policy type research? Is it qualitative work? Is it community-based work? But it's about picking the gaps that solve the purpose, move forward. There's no doubt that the translational focus of what will be this huge precinct once it's delivered is an area that we actually have to think more smartly about where we're trying to go. So I want to finish with a conversation around Health Workforce Australia. Fascinating. Other area aside from chronic illness, because of my job, has been workforce planning and modelling. So there's been a surfacing supposed tsunami of medical students, and I'll actually deal with nursing in a minute. There is no tsunami. Can we just close that loop down now? It's just a matter of how we position the medicos into the future. But what was missing about 5 years ago, and one of the things we said in the National Health and Hospital Reform Commission, was we needed some national workforce planning and ability for Health Workforce Australia, which was created in parallel to our work, to drive some workforce reform, create new training spots, but actually most importantly to model our workforce into the future. So there was a gap in policy. We didn't have the data. We couldn't clarify whether we had enough medical students coming through or there wasn't enough medical students. So the issue that I've increased, and I work with HWA as a clinical lead or clinical support person around that, and if you look at the report, Health Workforce Australia 2025, that has been absolutely groundbreaking. For the first time we can have a debate about whether we've got enough medicos across Australia and we can control this growth need for medical schools because of other policy issues. So that gap in services is what I learned out of that piece of work, and that's really guiding lots of thinking around medicine. Importantly though, it's actually evaluated for nursing and for other allied health groups, because if you look at the nursing side of the equation, we will have a huge gap. While we're perceived to have an oversupply at the moment, by 2018 we will have, when many nurses will retire or go to move on to other things they would like to do to finish off their lives, we will have a gap in nursing numbers. And that starts to set another policy agenda which is about providing key data which is about workforce, that issue of workforce and trying to marry that in. So I guess what I'm so that's another evidence where you can actually find a gap, get the right research framework, get the right policy players around the table, the colleges, the universities, and I can't emphasise enough that health policy requires, I was thinking as Maria was talking, it's a very team-based work. You physically can't do this desktop-wise. You've got to think through carefully when you put your teams together, who do I need? And increasingly I think as there's a move to bring consumers and into those research on day one, it's actually a very good barometer. Does this make sense? So there's things that we as researchers think, that's a very good idea. And I go home and have an argument with my son and my wife and they say, it's rubbish, Justin, it's not going to work type of conversation. So I think it's about getting a sense of that balance. It's about bringing teams together that you can actually build a relationship of trust, that you get all the views before you move forward, and looking for where those gaps are being served. Now and I think that's probably the lessons I will put on the table. Happy to take questions, but great place to work, but it's a long haul and you just need to think through, be patient through the discussion as you build your influences as you go forward. So I'll stop there.
Thanks. And I guess, having been in the field for a while, when you look back 20 years and what the situation was like then to what actually has been achieved, it's quite gratifying. But when you're an early career researcher and you haven't got that hindsight, it feels like it's overwhelming. And I think just having a team-based approach is good, because you can work with each other and support each other. If you're on your own, it's really tough. Speaking of being tough, if people at the back would like to sit, we have a whole row of empty seats right down here at the front. So while we're waiting for the first question, please feel free to move down here. Does anyone want to ask Justin any questions? Over here.
I'm not sure it's really a question. It's Linda Mundy from Queensland Health. I've spent a lot of time in the university, and now I'm experiencing the joys of being in Queensland Health. I've just come back from a really terrific conference where I've seen other units like we've had in Adelaide University, Health Technology Assessment, and they're actually operating from within the health systems. So they've got teams of researchers and like huge teams dealing with data, looking at trends, looking at solutions, priority setting, but they're sitting in the Department of Health. And we've never had any communication with the Department of Health. It's always seemed to be a closed chapter to us. And I think they're the links that we've really got to try and form, and I don't know how to go about doing that within our system here. So I'm really interested in that area, and a lot of what you said, Justin, really resonated with me. So I don't know whether you've got any solutions for that.
I think you're spot on. I think first off, the more data we have, in essence, the easier it becomes, because you've got a debate you can start having based on evidence, or not so much evidence as in gathered evidence, but you can use data to build a story. And just interestingly, in South Australia, they're just about to set up, from a partnership with SA Health and SAMHRI and other players, an elite health service group to try and look at problems, issues that have to be solved from a health system perspective. So it goes back to what I said about there's a problem that needs to be solved. Our job as academics, bluntly, other than writing publications, is to actually solve the problem, is to come back with a set of problem-solving skills. So I think you're right. I think what will make this work in a health policy sense is groups inside the actual policy generating groups. But my intuition increasingly is that we'll get better and better as people trust is pretty key. And secondly, information is, because you can then start having a debate about what's really going on. For example, the classic debate at the moment with the system is the frequent flyers. And when you start identifying those group of patients who go in and out ED, who are in their 80s, and developing policy solutions and community-based solutions that we as academics can work through, that's where we become useful, I think. So I think you're right.
Hi, Tori Wade from Discipline of General Practice at the University of Adelaide. Justin, one of the problems that we really face is when you're designing solutions for health, they often involve solutions of community and social care as well. So the Advanced Community Care Association, which produced a metropolitan-wide hospital avoidance program and was really starting to work, and we're going back, 8-10 years now, for exactly that group, got shut down because most of its packages of care were not health. They were about social, community, finance, housing, So how do we get that aspect into the agenda?
I actually think there's some set of options opening up around that space. I've just been recently talking about this. I think as academics, if we can clarify what the chronic care model, for the sake of words, an integrated care model is, there's a couple of things I think are beginning to open up. If you look at alternative funding models, which is things like consumer-directed care, things like social impact bonds, National Disability Insurance Scheme, I think we're going to eventually end up having to have in the next 5 to 10 years bundled of Medicare payments around these types of clients, these types of consumers. So I think the finances, the system's realising they can't just rely on fee-for-service or silos of funding to make this work. And I think that's where the likes of your team becomes very important, so the health economist in that space, because reality is we've just done some work in Port Lincoln around a new community-based care around musculoskeletal disease, and it's going to fail because we have no financial model to make it sustainable. Beautiful piece of research. It's lovely research. You know, really proud of the team we put together for this one, but it stopped dead because we've got no financial modelling. So I think we have to realise that in your structures around health policy, you have to have, as Maria says, there has to be, the reality check is there's got to be some dollars in this discussion, even if it's a possible 5-year model down the path, down the track. So I actually think the system will have to look at bundles of care around these packages, these types of models. I think your group was 10 years too early, is my view at the moment, listening to it all. Fantastic group, brilliant group, but I think 10 years too early, Tori, so I think you might have a rebirth in about 5 years' time. All right.
I guess the other thing, Tori, too, is to how do you capture that information so that people don't have to reinvent the wheel in 5 years' time? So how do you get that information somewhere so that it's still accessible?
Karen Williams from Flinders.
Hi, Karen.
How are you going to get Australians to change the way they think about picking their clinicians and practitioners?
I guess there's a couple of things that come to mind. Reality may do that. You know, some of the recent changes around Medicare and the co-payments are going to force people to be more thoughtful about where they want to go. That's the first thing. Second thing, there's no doubt health literacy issue, informing people more about their choices, about what they'd like to do, is part of where we have to go as a community, as a society. And one of the things we did within the Commission is starting to look at things like health education in schools, so that you actually build from the bottom up. So the bit that makes, we have to think of as health as a community-wide issue that you gather when you're 6 or 7 and start talking about your information about what it means to be well for the sake of a discussion. So I think there needs to be a groundswell in that space. I think we have to probably use the web, the internet information better as we move forward to try and clarify it. But I don't think there's an easy answer. But I do agree with you. Some of the answers for the reform has got to come from the community. They've got to demand what they need. And we've got evidence, for example, with breastfeeding and birthing, where they chose, they wanted to change the system to actually help them to move forward. So I think, Karen, that's sort of where we talked about it, but it's a big issue. It's actually quite an exciting piece of research, and maybe that's something that we do some work in South Australia around that space.
Okay, we'll leave the questions now, and then there'll be plenty of time for that later, and we'll move on to our third speaker, Professor Judith Dwyer. Now, Judith has worked in the Flinders University Department of Healthcare and Management for 8 years and was formerly the head of the Department of Health Policy and Management at La Trobe University's School of Public Health. She was also a former CEO of Southern Healthcare Network in Melbourne and of the Flinders Medical Centre in Adelaide, and has worked in the Australian health system for more than 20 years. Something magic about the 20 years, isn't there? And she's worked in this area in a broad range of community and hospital and government settings. Judith's research is focused on health system governance and design, with a particular interest in Aboriginal health services. She is a research program leader for the Cooperative Research Centre for Aboriginal and Torres Strait Islander Health, and is Deputy Chair of the Board of the Cancer Council South Australia, and also a member of the Board of Cancer Council Australia. Judith, over to you.
Ellen. Thank you very much for the opportunity to talk about this really fascinating problem of trying to make sure that your research makes a difference. Is my mic working? Yeah? Not sure where the mic people are. It's all right. There's always a hardware solution. Just bear with me. Is that better?
It sounds so good.
Okay. So I was thinking while I was sitting here that I need to, before I tell you my research stories and my learnings, I need to do a couple of things. The first one is I want to also acknowledge that we're meeting on the traditional lands of the Kaurna people, and I want to pay my respect to their elders past and present, and acknowledge Aboriginal people who are here with us today. I also want to say that the work that I'm reporting on is the work of many people, And I want to acknowledge Kim O'Donnell and Janet Kelly, who are both in the room, who've made significant contributions to the work that I'm talking about. But there are many others, and if there are others in the room that I haven't seen, my apologies. The third thing, by way of preliminary, is that it occurred to me that I'm going to be talking about research on policy, not research that hopes to be relevant to policy. And we'll come back to that at the end. Okay, first research story, a project called the Overburden Project, which some of you will be familiar with, I guess, but it was looking at the way that governments fund and regulate Aboriginal community-controlled health services. So you can see already this thing, we are, turning the evaluative gaze, to use postmodern language, on the policymakers themselves, on government, which is, which can be an uncomfortable kind of position to be in. We started thinking about this project in the very beginning of 2006, and we only finished the work in 2011. Now, we published before that, but by the time we really finished, it was 2011. So just pointing out, this is a 5-year proposition, this project. What we documented was something that everybody in the world of Aboriginal health services, both in government and in the field, knows, which is that these organisations work in a funding environment which is complicated, fragmented, and brings a huge overburden of administrative work. It is, I know. I'll give you that one. So I won't tell you how we did it, because that's not the point today, but we documented this thing that everybody knows about. But we were the first people that really documented it. And what happened in response? Well, it was very gratifying. Our first publication was in 2009, and in 2010, HSRAANZ, which was, I don't know what it's called now, but the federal funding body in federal health for Aboriginal health services, reformed their funding model, and they cited our report as one of the prime reasons for doing that. So we felt pretty good about that, and it has meant that the federal government has moved to some longer term contracting, and they have rolled some things up together that were previously in all sorts of little bits, and it has made life somewhat easier for the services. Of course, the real complexity is that some of them have got about 16 different funders, so one funder, even if it's the main one, changing doesn't really solve the problem. However, you can say that research had impact. It's also informed various reviews. Do you remember a couple of years ago there was a big headline about $3 billion wasted in Aboriginal affairs? And it was that headline came from a report that had been prepared in the Department of Finance for Cabinet, and this guy, Dr. Johnson, had gone through across the full range of Aboriginal affairs, looked at what was happening, came to the conclusion that a lot of what was happening wasn't effective. That report also cited the work that we had done as good evidence about the way that what government is doing isn't working in Aboriginal affairs. And just by the way, that whole event was, as far as the mass media was concerned, was a disaster. But the stuff that wasn't in the press about that was that the findings about the Aboriginal health field and the way that it's funded and so on were much more positive, and the recommendations for change in that area were marginal. And to do with this sort of bundling up, that needs to happen. So it's very nice when you see the policymakers citing your work, and the Australian National Audit Office also cited this work. Are things better for the services as a result? Well, yes and no. I've talked about OATSE changing how it works, but of course they're not the only funder, and a lot of the other funders are still doing very silly things. There has been real progress on the data that is gathered about the services, not because of our work, but because it was happening anyway, and systems are becoming better, and that side is also improving. And in fact, in some areas you can get better data about what's going on in Aboriginal community-controlled health services than you can in mainstream primary health care. But there is a knot that is still to be solved at the heart of the contracting that goes on between governments and these NGOs that are Aboriginal community-controlled health services, and that is about a way to do accountability that's workable in an environment where there is a very low level of trust. That's something we're worrying about now. Okay, so that's a story where some fairly difficult research on the work of governments actually was the results were accepted, and some improvements have been made, though there is still a lot to be done. You know, when you go to a job interview and you get asked to say your fault and you say, oh, my problem is I work too hard or whatever, you know, the second question was supposed to be about telling a story where things hadn't worked. Well, I'm going as close as I'm willing to doing that. I want to tell you a little bit about a project called Managing Two Worlds Together, which was about which still is about the way that care, particularly in city hospitals, is provided for Aboriginal patients from the country, from rural and remote areas in South Australia. This work was funded by the South Australian government. The one word that probably you could take home to remember the Managing Two Worlds Together project is complexity, in the sense that these patients have the most complex patient journeys that you could possibly imagine, including for very remote people travelling for 3 days to get to an outpatient appointment and then possibly being 20 minutes late because the bus was late and being told that you'll have to come back next week. So, these are very difficult situations for the patients. We started thinking about this project in 2007. It was funded in 2008, and it's since it developed and got more funding, and so it isn't even actually really finished yet. So again, these are very long-term endeavours. Again, I won't tell you about the results because there's a website. Just type in Managing Two Worlds Together and you'll find it. But we developed ways of framing what seemed like this incredibly complex and difficult patient journey. And we think that those framing ways are a contribution. But what we discovered in talking to the people in hospitals, and let me say, we talked to 60 healthcare staff and some patients, Aboriginal patients who had undergone these journeys, that a lot of the people were very thoughtful about what they were doing, and they were designing solutions to unbelievably difficult situations, sort of on the run, day by day, and in effect kind of having to redesign them a lot of the time because they weren't being bedded down. One of the mysteries at the bottom of that problem was this idea of equal treatment. And I'm just going to read you one quote from someone that we interviewed talking about the way of providing care for country Aboriginal patients. It was like you treated them like any other Tom, Dick or Harry that came through the ward. We did our normal treatment, did what we had to do, and when it came to discharge, you just did the normal protocol for everybody, and that's been my experience for 20 years. ... I guess I recognised that it wasn't working. And, that sort of sentiment was expressed more than once in these interviews. And when you dug down into it, what people were saying was that they had a commitment to the principle of equal treatment, which in a public system is actually a good thing, but they were failing to add on the caveat that's always there about equal treatment, which is according to need, because there was an inhibition against recognising the legitimacy of the needs or the legitimacy of responding to the needs of this particular group of patients. So what we discovered, which was not a surprise, but what we found we were up against was institutional racism. Now, I'm not talking about the minds of the staff involved, not even that one who had moved on, but you don't have to intend to be racist when you work in a system that's set up to enable that, in fact, to almost require it of you. And what we figured, so then we looked at, that we have all this wonderful, beautifully worded, high-level policy, the cultural respect framework. We have legislative provisions that say, in the Healthcare Act, one of the objects actually says that care has to be provided with respect for Aboriginal cultures and ways. But that hasn't filtered through yet. Mind you, that Act was only made in 2008 and nothing's been tested from it yet, but it will in the longer term have an impact, I think. But what we concluded about that was that the staff, who are trying to provide good care, are left with a situation of both responding and denying the need to respond, or at least the system is denying the need to respond. We think that the answer is, or the next step is to move that high-level policy down into operational policies and programs. Just like we did, for example, when the health system was confronted with bloodborne viruses. And, everyone stood around scratching their heads and thought about quarantining people with HIV for about 3 minutes. And then they figured out universal precautions. And then there were several years when you couldn't turn around, but you didn't find a new policy or protocol or a new sharp spin or, whatever to respond to that, to make care safe for both providers and patients in a different kind of world, different environment. What we haven't had is that cascading down into operational policy and procedure of a serious, sensible, business-like response to the huge complexity of the patient journeys for this group of patients. These problems affect a lot of other people as well. It's just that country people who are Aboriginal have got all of them. All of the difficulties of access affect them and they interact with each other. If we made it better for those people, we would make it better for a lot of other people as well. Okay, so I said this was my go at a failure story, and I can tell you that an Aboriginal patient coming down from Oak Valley or somewhere to Adelaide probably wouldn't notice that things had changed radically as a result of our project yet. But we remain hopeful. Janet in particular has been doing some really good work on using the tool of patient journey mapping to help staff understand what it is that needs to be done and find a way to build it into normal business. So we're hopeful about that. But we've also concluded as a result of this research that the Australian Constitution needs to change. And actually we think it might. Not because of our work, but we think that we might indeed get change in the Constitution in the next couple of years. And if we do, we will then have a real basis on which everybody can feel comfortable that it is a normal part of delivering good health care, that the conditions and needs and norms and ways and priorities of Aboriginal people are just as legitimate as those of everybody else. So, this was a sort of seemingly small project. How do we make the care work better for country Aboriginal people coming into city hospitals in Adelaide? That led us into some really very basic national problems that the whole country, we think, confronts. We think that making patient journeys visible is a good idea. we think that the insights about planning and organising for complexity are useful organising principles that could be useful to hospitals, that are proving useful and can be useful to hospitals. Okay, so what are the general learnings out of those two stories and my, experience of positioning myself and with other people, both sort of staring at the actions of government and offering advice to governments on how they could do better. The first thing is that I've had the great privilege of, as a sort of well-meaning white girl, working in an environment of where I have authorisation, proper authorisation to do my work, and that's through the CRC for Aboriginal Health, which is an Aboriginal controlled organisation that provides a safe space for Aboriginal people, researchers and non-researchers, and non-Aboriginal researchers to work together. So the policy relevance of what I've done has been in the genesis, in the very first dreaming about the projects. That relevance has been built in, and I have felt safe in doing this work because I feel authorised to do it. So engagement early and often, I guess, including with government in interesting ways. Public servants are wonderful people and find creative ways to do heroic things sometimes. The other thing that I've been sort of focusing on a bit as I've talked is timing. Policymakers want the evidence by 5 o'clock Friday, and I've been telling you about how long it takes to really produce the evidence, and there is no solution to that. People say to researchers, how can you do it quicker? And a lot of researchers have thought about that, but for this kind of work, the real answer is no, we can't. This work has to be done slowly and carefully. The only thing we can try to do is get the timing right, so that, by the time we get to the end, we've answered the question that the policymakers hadn't thought of 5 years ago. That's hard, but it takes a different kind of work to have it by 5 o'clock Friday, and we should stop pretending that we can do that. The other thing is that even though we were working on things that everybody knows, in a lot of ways, if you have strong theoretical frameworks and gather good data, then you can present that story in a way that is more useful to people. So particularly going back to the overburden project, everyone knew that the funding was a mess. We not only, gathered the data about the complete and utter and quite visually amusing mess that the funding is, but we did it using a theoretical framework about contracting that holds within itself the answer, as it were. Strong theory does that for you. It gives you the framework to make sense of what you're looking at, and that my experience is that you either have to find or make a strong theoretical framework to be able to have a story that is not only credible but provides real pointers about what way to go, reliable pointers about how to go. And the final thing I want to say is that working in the way that I and others have been working with community organisations and with government is kind of a bit wild and hairy from a research point of view. Oh, for the elegance of a randomised controlled trial. You don't get it in this kind of work, and you can't simply pursue, the angel dancing on the head of the particular pin that you're interested in. It's a different way of working, but there are frameworks for doing this as well, and you can get there. It may take longer, but maybe not. I haven't seen any evidence about that, so I remain unconvinced. I'll stop there.
Thank you, Judith. Okay, open for more questions. And we have the roving mic, so put your hand up if you need a question. Down the front here. Perhaps you'd also like to think, well, what sort of key messages are you going to be taking away when you leave here today? Go on.
Stephanie Moss. I'm an alumnus of UniSA. I don't know that there is equal treatment. When I've been in a hospital doing my clinicals as part of my studies, one of the things that I've noticed is that people have a thing about hygiene with Aboriginal people, and they almost push them away, and they assume that they have bad hygiene and so on. And sometimes I've seen Aboriginal people pushed into corridors and sort of left waiting while other people are dealt with, and staff don't deal with the Aboriginal patient much at all. Now, I don't know whether people have seen the latest New Scientist, but there's a Dutch chap, who's been studying his own microbiome. I don't know whether you know at the moment with citizen science and with individual scientists, they're starting to look at microbiomes either in the environment, in looking at infectious diseases and so on. And in any case, this Dutch scientist, one of the recommendations that he makes is that in fact you don't wash yourself as often, and that actually improves the way in which the microbiome work on the surface of your skin. So and he actually discusses the fact that, okay, he's been smelly to his friends and he's had to make some compromises, but the thing is that people's attitudes towards cleanliness is rather strange, and some of the research done by Dunn in the United States using citizen science shows that we're absolutely covered with all sorts of things, and that has to be taken into consideration by health workers too, and they have their own microbiomes that they've got to deal with too.
And I know some teenagers who'd be very pleased to hear what you just said. Let me just say that I didn't suggest there was equal treatment. I said that that's the principle that people have in their mind, that in some ways acts as a barrier to being responsive. Yeah.
Mm-hmm. We have a question down the back, and then up the front.
Thank you very much for your talk. My name is Jill Benson. I'm a GP. I work with remote Aboriginal communities and with newly arrived refugees. My question is about the gap between research and policy, because I think what you were saying was that you were looking for an answer that would give us a way into health equity for people who are vulnerable in our health system, which is something that I think we all want, but that the research was showing you the complexity of that. My question is something that I struggle with. How do we bring research that shows us a way into health equity into something that is palatable for policymakers? Because what we're really bringing is a flexibility and a complexity that isn't necessarily something that can be written as a protocol that looks like a policy.
Thank you. Look, the complexity, we think actually hospitals love complexity. And clinical complexity is something that is really well accommodated. I mean, if you're going to go to hospital, you want a good, strong, manly disease, you know, that can be readily identified and that's got a treatment. And the more complex, in some ways, the better. So what the complexity idea was about the fact that the system could be designed, and in some ways is designed, we found in our research, to accommodate complex patient journeys. So our argument is that patient journey complexity should be something that the hospital system can accommodate to, just like it can accommodate to clinical complexity. So we that was that's our go at finding a way of kind of operationalising the situation of and the need, a response to the needs of this particular group of patients. So there's a couple of clinical units that we worked with in Adelaide that had people in roles of coordinators for care. So their job, they were part of the clinical team, but their job was to look outwards from the hospital. And they dealt with the primary care providers before the patient arrived and as part of the discharge. So that was a response to complexity that was sitting there as a sort of infrastructure. Not every Aboriginal patient from the country needed it. Needed, some extra coordination, but some of them did. That system was there and ready to be brought into action when a patient who did need it was coming down. So it's that kind of complexity. The equity thing is also very complex, but I didn't explain.
We have another question down the front, Matt. And then, yes, someone in the picture.
Matt Fisher from Southgate Institute at Flinders. It seems to me that in governments, state and federal, and in the delivery of public services, there is a couple of things going on. One is about sort of reform process that is now almost constant, that government departments are in the process of constantly shifting the deck chairs around and changing how people work, and people are in temporary positions, and it seems almost endemic to me. And the other thing I think is that there's always a relationship between a bunch of regulators and a bunch of service deliverers, and that there's a danger in there of the regulators trying to micromanage the service deliverers constantly through more and more policy. So I guess the question is, as a health research community, is there a danger that we actually contribute to that preoccupation with the idea that there must be a perfect formula out there somewhere, and we just need to constantly reorganise ourselves until somehow we latch onto it? And are there things that we can do to avoid contributing to that?
I might open that up to all three.
Yeah, that might be a question for all of us, but it seems to me that that risk is there, whether we provide evidence or not. And we can take that risk into account in our work and try to minimise it, but we can't control what people do.
Is that better? If I have it up closer to my mouth? I think it's a reality of what we deal with. So I think the way that I've managed it over many years is to try and identify the more senior part of the bureaucracy that may stay longer, if I can sort of play out my thinking a bit. So if you start working out what's your key contact and the person who understands the issue as best as that you understand you're trying to deal with, is that one-to-one relationship is crucial. And that's the face-to-face work. And that's the issue of going, whether it's SA Health or whether it's the networks or it's Commonwealth, it's getting those one-to-one relationships that allow you to get those phone calls, that type of working. And I think that's the only bit of work that when I started this work 20 years ago, some of my earlier mentors said they all change. They won't be there in a year and you'll have to find someone else to communicate with. I've sort of gone past that. The reality is it's too important a topic, and if you've got something that needs to move forward. So I think it's that self-confidence. If the story's right, the time will come, and that you just need to identify the key decision makers as you move forward, including the politicians. And it's really important that you build those relationships with the politicians in the same space.
Do you want to add to that, Maria?
Could I just make one comment on that?
Of course.
And if you are not Justin, and the Minister or the Chief Exec don't take your phone calls, then I would suggest that you do work with people at whatever level you're at, because with any luck, in 10 years' time, when you are like Justin, they will be.
However, just to build on that one, That's a very good response. I stand corrected. It goes back to having the right team and building the team around both people who are building careers but also who are well established in the networks.
Yeah.
There is absolutely, I'm sorry, the networking is really important in this space.
Yeah.
And while Judith has had a quiet knife in my back, which I'll accept on, which is a well way to put it's quite clever.
Well networked.
It is a reality check of this work. It's around, and retired politicians, people who actually have access to networks, are fantastic people to work with. And they'll get you into these conversations if you've got something that's a way of working.
Yeah.
And that's the reality of what we deal with. We're not dealing with a randomised controlled trial with patients you recruit and you publish in Lancet and they love you to death because you get the media that comes with it. This is slow, subtle, sophisticated partnership building the story, but it's really rewarding, as Judith and Marie have just talked through, when you get it right. Because don't walk. No, it's a great place to be. That's all. I'll leave it at that.
I'll just agree, because even when you do have the great randomised trial, it doesn't mean that anyone's going to want to take it on board. And the networking is absolutely vital, and as at many levels as possible. And yes, people will change, but it's the only way. Yeah.
And I think even though people change, that is an opportunity to get to know other people in those positions, and that expands your network, and you never know, they come back. But yes, it does take time, and there's a skill to it. It's at conferences, it's a very good opportunity to start that, so keep that in mind. Now, we have another question there, and then one down the front.
A question for Judith. It's Gillian Marshy from the University of South Australia. Judith, I'd just really like to ask you, one of the things you mentioned was the importance of a strong theoretical underpinning within research. I'm really interested in that, and I'm sure a lot of people are. I know from the time that I've been working in research that this is something that has a huge impact, and for me, within Indigenous research, I find this is something that we often come back to in our discussions. Can you give us a little insight to how you would define strong theoretical underpinnings and why they're so important in establishing a good framework for research? What does that mean to you?
That's a hard question, actually, isn't it? It's there's something, you know, that concept of the unconscious competent or whatever it is, that, you know, that tacit knowledge that it's hard to surface. Often I feel like I go searching for a theoretical framework and I don't know what it's going to be, but when I find it, I recognise it. Yeah, and I mean, I promise not to tell you about contract theory, right? Because it's really, really, in some ways, abstruse. But sometimes people have been thinking about these things in fields, you know, a bit far away from you, and with luck, sometimes you find them. And then other times you've got to develop them. I mean, in the Managing Two Worlds Together project, what we found was that there was not a method of patient journey mapping that worked for the situation that we were in. And in order to develop one, which we think we've done, you have to go really deep into some theory, an Aboriginal theory about the dimensions of health, and another one that we developed ourselves about how to organise the barriers, as it were. But yeah, getting all this stuff organised is what theory does for you.
Thank you. Now, we've got one question down here, and then John Carnan can ask the last question. And what I want the speakers to do after that is to give us their take-home message, and then we'll draw it to a close. So,
okay. Thank you. Lee Martinez. I actually hold a joint appointment with Country Health SA and the University of South Australia. My university appointment is as a mental health academic, and with Country Health, interestingly, the title of my position is Knowledge Translation, which has been interesting and a journey that I often ask myself, am I doing it? Just really, I just want to add some comment. But first of all, around the Two Worlds, bringing the Two Worlds Together project, we in Port Augusta, I actually live in Whyalla, but in Port Augusta, Janet worked with us to use that framework to develop a suicide prevention network, which is still running in the community on its own and with very little input from the health service we attend, but it is very community driven. So thank you, Janet, for that, wherever you are. And so that's one, I mean, it did work in that space, and we've attempted to use the mapping tool, I guess, in other areas, but in Port Augusta it has worked really well. Also, I think the complexities that you talked about, Judith, of the patient journey for an Aboriginal person, and similarly in mental health, those complexities are very similar, and if you add an Aboriginal person with a mental illness to that, then it even gets more complex. And I just wanted to make a comment about my role in that I see it having your foot in both camps as a huge opportunity. You get, with my position in Country Health, I actually get to sit on like the mental health executive and their high-level cabinet. There's a mental health cabinet which sits above the executive, so I get to sit on that, and that provides, I can see opportunities sometimes of how we could bring research into practice. But following on from what, picking up from what everyone has said today, it's a struggle when you're the sort of the one person in there, and in some ways if we could get more people that are doing this type of thing and form a network and then have support around each other would be a good thing. So
you might
thank
like
you.
to talk to the PHCRIS research manager manager knowledge exchange sitting at the end of your row, Christina. And anyway, thank you. Did anyone want to comment on that? I think it is a tough position, and I think the more support you can get, the better. So the final question right down at the end. Thanks, John. It's rather fitting that you asked the last question since you started all this.
Thanks, John Conn, University of Adelaide. Just want to pick up really on one of Justin's points about his research in Port Lincoln, which, as he said, fell over because we didn't have a financial model to back up the intervention. And I think that's often the case with a lot of health services research in particular, that a lot of interesting, innovative interventions are evaluated, shown to be effective, but because there was no planning or concept about how those interventions were going to be funded, if they were shown to be effective, they fall over. So I was just wondering if the panel had any experience in terms of testing or building in funding options to an evaluation in order that it has some sustainability after the end of the evaluation.
That's a very good question, John. It's a difficult one to end off the meeting with. I think we probably, as health service researchers, need to start with the premise that you have to make it sustainable, if that makes some sense. So the lesson we learned out of Port Lincoln was that we tried to work with Country Health to build a sustainable model from a policy framework, and initially those conversations were going very well, then some other things got mixed up in the discussion around politics and people and stuff. So I think it's, as I said earlier, when Tori asked the question around the opening up the different funding options, I think if your research is 3 or 4 years out, it's about starting on day one and having the debate with the policy people and the funders and people such as yourself, and to say, well, within the financial policy framework of Australia, if you tweaked X, Y and Z, could you make it sustainable? So, for example, Medicare, can it be used differently if there was a different way of handling health assessments for the sake of a discussion? So I think it's actually starting the debate about sustainability as you start the research and building it into your plan. And then I think the other thing that's surfacing for me is using, and I'm not quite sure, Miriam may be able to comment more because she's better wrapped up within HSRAANZ than I am at the moment, is allowing your funding pool to continue past the project to actually have some time and resources to think through the sustainability and write about it and negotiate with people and think it through. So I think that's where the NHMRC model and maybe the translational faculty will move it on. And again, Maria may want to comment, but I think that's where we have to try and go as self-services researchers, is retain the ability to do the thinking post the research, which might take a couple of years to come to fruition. I don't know whether you want to comment.
Yeah. I think that's actually a really important point. The project grants don't actually allow you to do that, so it's not unless you've got some extra flexibility in the funding, whether it's a CRE or I'm not sure what the translation faculty will come up with. I don't think there's a lot of money there. That's probably the only scheme at the moment that actually has translation at its core, and actually you get judged on that, and there is an expectation that there is a strategic plan around something in that area.
Okay. Well, thanks for the questions, people. Now, just to wrap up, I'd like to ask you, each of the speakers, what's the take-home message that you want people to walk with outside the door? Maria, you started, so let's start with you again.
I think it is clearly a very complex area, strong vision at the beginning, but flexibility through the process to be able to adapt and be able to take on board all the new information and the changing situation that is actually happening along the way.
It's complex, it's very rewarding, and the key thing for me is to build the right team from day one that can cope with lots of nuances as you move forward. And I think it's the bit that I've learned over 20 years is you build the teams, you stay together through the first 5 years and the further grants, and you get little wins, and then you build momentum and trust, and people come and talk to you about, well, what do you think about this concept? So that's really it is. But it's really a very rewarding space to be in. So I think it's something that I think the three of us obviously all enjoy.
And finally, Judith, how do you propose to reduce the gap between research and policy?
I'm going to answer the first question. I think that there's a big message from the experience over the last 20 odd years of the Cooperative Research Centres program, which is about working with industry. That CRC language, what it means is health system and government for us, working with industry to define research questions or research areas and then questions, so that you know that you're looking at something that somebody's interested in knowing about.
Thank you. So please join me in thanking our speakers. Been very good. Now, as we mentioned at the beginning, this is the first of a series of 3. Our next session is on June the 16th. Here in the same venue. You'll be given more information as we develop it, but it'll be looking from the other perspective, from the research user, the policy makers' perspective. So it should be a very engaging, and tell other people about it too, because you don't have to be here for the first to come to the second and third. You can come, more people can come as well. You have evaluation forms on your seats. Can you please complete them and put them in the box as you leave through here? Thank you very much for attending, and we look forward to seeing you next month. So have a good day. Thank you. Thanks very much. Thank you. Thank you. I don't know. Smart. Thanks for it, Judith.